Hello and welcome everyone. I'm Dr. Bishal Gyawali. I'm a co-founder and co-leader of Common Sense Oncology, and I'd like to welcome you all to this important CSO webinar on the highlights from ASCO 2025. As you know, ASCO annual meeting has just ended, and it has given us lots of trials to think about and how it will affect our clinical practice and policy moving forward. And I hope you have all been aware of these major trial and news that are coming out of ASCO 2025. The purpose of today's webinar is to do a critical appraisal of the major trials that might or might not have an impact, in terms of clinical impact. There are two ways of thinking about it: if you immediately change practice or if you decide not to change practice. I think both of them are impactful. We are going to do a critical appraisal of these trials in today's webinar. So a warm welcome to you all, and especially thankful to two of our Common Sense Oncology fellows who are going to present these trials. So please welcome Dr. Haydee Verduzco Aguirre and Dr. Omar Abdihamid. Both of them are our inaugural Common Sense Oncology Fellows. Dr. Haydee is from Mexico and Omar is from Kenya. So we'll be trying to put our critical appraisal also in the context of global and international relevance of these trials. And these are the trials that we are planning to discuss today that you can see on the screen. But I think it's best if we do Q&A after each trial so that we can discuss about that particular trial. So please keep Q&A coming through chats or directly. So with that brief background and introduction, I'd like to request Dr. Haydee to open up. I think she'll start with discussing the Serena-6 trial.
Okay, so as Bishal was saying, we're trying to frame the discussion through a critical appraisal lens and trying to discuss whether these results actually have an impact on our routine practice and whether these are globally applicable. And we'll try to frame this discussion through, some of you may be aware of the Common Sense Oncology randomized clinical trial checklist that has been recently published. And we'll try to use this throughout all of our discussions. So the first trial we'll be discussing is the Serena-6 trial. This one looked at first-line use of camizestrant for emerging ESR mutations in patients with advanced breast cancer. This trial enrolled patients from 2021 to 2024 and included patients with hormone receptor positive advanced or metastatic breast cancer, who we know that may harbor some endocrine resistance mutations such as ESR1 in about 5% of cases at the start of first-line treatment. We also have some information that these mutations may emerge over time in patients who are, for example, treated with an aromatase inhibitor and a CDK4/6 inhibitor, up to 40% of patients at disease progression. We now have some targeted treatments directed at these ESR mutations. And the hypothesis of this trial is trying to start treatment at an earlier time point through routine monitoring of emerging ESR mutations and switching treatments upon detection of these mutations, even before actual radiologic disease progression. So this is roughly the study design. Patients were enrolled and included in a first phase of surveillance for detection of ESR mutations, which was done by NGNs done every 2 or 3 months. And if they developed or a new ESR mutation was found and patients did not have radiologic progression, they could be randomized in the second phase of the study, in which they were randomized to either continuing on the same treatment that they were, which was an aromatase inhibitor with a CDK4/6 inhibitor, or switching the aromatase inhibitor to camizestrant as an oral selective estrogen receptor degrader. So since patients weren't actually having radiographic progression, I think the control arm in this trial is technically appropriate because patients didn't have any need to switch a treatment that was actually continuing to work in the traditional sense. The primary endpoint of this trial was progression-free survival, and they also looked at second progression-free survival and overall survival and some of the other things that we will be discussing. So these were the endpoints, and additionally, they also had some interesting quality of life endpoints. The main one that they discussed during the presentation at ASCO and the subsequent publication was time to deterioration of scores using some of these scales and global quality of global health status through this questionnaire QC30. They also had some exploratory endpoints through patient-reported outcomes, and this interesting measure that's called patient's global impression, in which they basically ask patients what is their own impression of changing their symptoms and treatment reliability and whether their health status has changed. Importantly, crossover was not allowed after patients experienced radiographic progression on treatment in either of those arms. And I mean, this kind of makes sense because camizestrant is not yet approved. So I don't see that as a main issue for this trial. So this was a positive trial for their primary endpoint of progression-free survival. Out of all of the patients that they included in the initial surveillance phase, around 16 to 17% were found to have developed an ESR mutation throughout the unknown duration of surveillance, which is not quite yet described in the trial or the subsequent publication. But among those patients, 51% had the mutation detected on the first test. So some of patients who had a mutation detected ended up not being randomized, and some of them were because they actually had concurrent disease progression, which excluded them from the trial. But regarding progression-free survival, I mean, as I was saying, this was a positive trial with a decent improvement in PFS, we could say, of around 7 months, from 9.2 on an aromatase inhibitor to 16 months on camizestrant. This is interesting because I wouldn't expect such a long progression-free survival on patients at this moment with just an aromatase inhibitor if they were developing a mutation that could cause resistance to this, theoretically, to these kinds of treatments. But there was also, they also showed some analysis on progression-free survival, on second progression-free survival, which at the moment of this interim analysis did not reach the pre-specified threshold that they were planning for. And OS data are quite immature at this moment. So to put all of this in context, I tried to do this slide showing where this would fall with the actual current evidence that we had. So in yellow, you can see the currently available data that we have from clinical trials in the first-line setting, which is our current standard of care with CDK4/6 inhibitors and an aromatase inhibitor. Patients usually have a progression-free survival of a little over 2 years on this treatment, which means that this time might be included, some of this time might be included in patients who were included in this trial because they hadn't had any radiographic progression yet. So this means that the actual benefit from switching to camizestrant comes after this. So the question here would be whether this is something that can actually provide some benefit in comparison to some of the other strategies that we might have at this moment. I mean, camizestrant, as I was saying, is not yet approved, but we do have other oral SERDs already out in the market, such as elacestrant. And there are some other strategies that have been tried, such as switching the type of endocrine therapy that we combine CDK4/6 inhibitors with, or actually switching the CDK4/6 inhibitor itself. So I'm putting here some of the results that we actually get on progression-free survival with those strategies, trying to compare how this would look when patients had a radiographic progression after staying on the aromatase inhibitor. And assuming that patients would get a subsequent treatment, this means that the actual benefit from this whole strategy, rather from switching early to neural cert, rather than waiting upon overt radiographic progression and then doing the treatment switching at this moment, the actual benefit in the long term might not be as great as it's shown in this trial. And here the question is whether this is actually impacted by two things, I would say. One is shown in this slide, the issue with declaring a patient as having progression at an earlier time point, which could represent a form of lead time bias, but also from the idea of this control arm it might be actually a suboptimal control arm if we think about it, since patients with ESR mutations are theoretically becoming resistant to these kinds of treatments. So if we're looking at the actual benefit and efficacy, the question would be whether this can actually bring some benefit in terms of quality of life. So regarding toxicity, the outcomes are not that different from patients who stay on an aromatase inhibitor, which is quite reassuring. There are some interesting side effects, such as visual side effects, particularly photopsia, but they did a very thorough assessment of the impact on quality of life from this, and there doesn't seem to be that much of an issue. What is interesting, however, is the global quality of life analysis that they showed. As I was saying, this was they analyzed time to deterioration in global health status, and going back to the protocol, the study design, they were doing response assessments and imaging assessments every 8 weeks. So as you can see, I put in a red line there on which would be around 8 weeks. And it seems like patients' quality of life in the control arm is actually deteriorating even before they actually had their first scan, which is quite interesting. And I wonder if this is in part related to patients. This was a blinded trial, a placebo-controlled trial. But I mean, these were patients who were already on a treatment that they were tolerating quite well for a long time. So there might be some signals for patients who were actually randomized to the control arm. And I wonder whether actually knowing that they were staying on a treatment, despite that they were found to have an ESR mutation, could have had some impact on quality of life, psychologically and emotionally. Okay, so in summary, do I think this impacts our routine practice? I would say not at this time. I would want to see subsequent results on progression-free survival too, subsequent treatment data use, and overall survival. And actually, SERENA-4 is also currently still ongoing. And this is looking at camizestrant in the first-line setting. So it's also important to consider that oral certs have not shown an overall survival benefit yet. And the actual clinical benefit for similar agents such as elacestrant is not that large. This is not approved yet, so we don't have any information on costs, but extrapolating from other similar agents, this might definitely increase as costs for patients and health systems. And there are many outstanding questions about whether it's actually beneficial for patients for us to implement routine NGS surveillance. As I was saying, one of the things would be the impact on quality of life of actually undergoing this surveillance with NGS. And as for global applicability, I would say it's quite low because mainly of two things: the added burden of repeat NGS testing. I mean, in many parts of the world, we don't even have access to a single NGS test. So this makes it quite difficult to implement in many parts of the world. And The costs of this strategy might be definitely higher compared to other strategies that might not produce such different results.
No, thank you. I think that was a great takeaway. Just to add a couple of highlights to what has just been discussed. I think use of PFS as the primary endpoint here is quite problematic because it is suffering from lead time bias. This is simply a function of treatment starting early in the intervention arm, uh, which will automatically lead to longer PFS. I try to think of this similar to what we do in ovarian cancer, measuring CA-125 and intervening early. And then, of course, you'll have a longer PFS, but PFS is meaningless in such situation. PFS2 would be more important, but yeah, I have a hard time understanding what key secondary endpoint means. Like, it's not like just adding the word key to the secondary endpoint does not make it a primary endpoint. So I'm not sure whether the trial has been powered for that. They call it a key secondary endpoint, but I don't know if the trial has been appropriately powered for that. I would be looking for PFS2. I think PFS2 can be a more meaningful endpoint in these situations, like it was used in SONIA too. But PFS2 and OS would make it more convincing based on what we are seeing right now. Forget about low and middle income countries, but even in high income countries, I don't think this should be changing any practice. There are some questions about would time to subsequent treatment be a more suitable endpoint in Serena 6 trial? I would personally think that anything less than OS or at least PFS2 would not be enough to change any practice. And is it possible to perform only ESR testing at a lower cost than full NGS? That is an excellent question, and the answer might be probably yes. But I think at this time, because it is not practice changing, I think there is no point in even doing that, just for the sake of doing that.
Okay, thanks. So I'll also continue with the other breast trial that we're discussing today, which is Destiny Breast 09. So this is looking at first-line treatment with trastuzumab deruxtecan and pertuzumab. As we know, our current standard of care for the first-line setting for patients with advanced HER2-positive breast cancer is still, after many years, the Cleopatra regimen with taxane, trastuzumab, and pertuzumab. And we have more recent data showing that T-DXd is quite highly effective in the second line and later settings. So this trial makes sense in that in trying to bring this highly effective agent to the first line setting. Patients in this trial, as I was saying, they didn't have any prior systemic treatment. They were stratified by hormone receptor status, whether they had de novo or recurrent cancers, and also by status of PI3K because of some information pointing to be this to be an important prognostic factor for these patients. So this trial actually randomized patients to 3 arms. The control arm was, as I was saying, the Cleopatra regimen. And the results that were recently discussed were mostly focused on the T-DXd plus pertuzumab arm. At the moment of the interim analysis they did, the T-DXd plus placebo arm hadn't met their criteria for superiority. So this remains blinded, that we don't have any results available for this yet. It's also important to highlight that this trial was started in April 2021, as I was able to find in clinicaltrials.gov, and that T-DXd was approved for second-line treatment in May 2022. So this is important because this trial did not allow for crossover, but it's good to have those dates in mind as well. And the primary endpoint of this trial was progression-free survival by central review. So as I was saying, this was a planned interim analysis. They've had a decent number of events showing that even with some stringent criteria for this interim analysis, there was quite a large benefit on PFS even at this moment, with a median PFS of 40 months in the T-DXd plus pertuzumab arm compared to 26 months in the control arm, with a hazard ratio of 0.56. And they also showed some results, early results on PFS2, but these are not quite mature. But this is interesting because I actually do see some, I'm not sure whether to say problematic issues with um, uh, treatments after progression. As you can see on the right side of the slide, patients who received treatment after discontinuation of the first line treatment that they received in the trial, we would expect, as I was saying, this trial was initiated in 2021. So even before TDXD was approved, or previous standard of care would have been TDM1. So you can see that in the control arm, very few patients received either TDXD or TDM1. And most of these patients received a trastuzumab-containing regimen, which could be either trastuzumab chemotherapy or combinations with apatinib or other targeted agents. So I wonder if this had some influence in these PFS2 results. I also tried to do this visual representation on how these results compare to what we would do in our usual practice today in 2025. So I'm showing here comparing the results from the experimental arm, the control arm in DESTINY-Breast09, and then comparing these two PFS results from what we would get in the ideal trial setting from Cleopatra in the first line, which had a PFS of around 18 months. And then using the data from DESTINY-Breast03, which is the trial that looked at TDXD in the second line. This trial has long-term results available. So in gray, this is the PFS that we get from using TDXD in the second line setting. And then we also have already the PFS2 results available for this strategy. So patients who received TDXD in DESTINY-Breast03, when we combine data from PFS and PFS2, they derived a benefit from TDXD and any treatment that they received after TDXD, a total of 45 months. So this would mean, in my opinion, that I would expect PFS2 for the experimental arm in DESTINY-Breast09 with TDXD and pertuzumab to be at least 60 months, if not more. And if not, I wouldn't consider this as superior to what we potentially could do with sequential use of these agents. One of the concerns that was discussed throughout the meeting and also in social media was the high risk for attrition that patients with metastatic HER2-positive breast cancer might have. So I would think, I mean, considering that, well, these results are quite immature at this moment, but that we don't have any overall survival signals so far, I would think that we could perhaps focus this strategy on those patients who are more at risk of having, I would say, a more symptomatic or catastrophic disease progression that might not be eligible to receive treatment in the second line setting. I'm here highlighting patients with brain metastasis at baseline. This was a very small subgroup in this trial, but as you can see, the benefit appears to be quite good in this population. And we know that TDXD is highly effective even in patients with metastatic, with brain metastasis. In on the upper part of this slide, I'm also highlighting patients according to age groups. And you can see that it was also a small group, but older patients seem to be not have as good outcomes as younger patients. And this brings me to my next point. Next slide, please. That this treatment strategy might not be for all. I mean, there are some important differences in the safety profile of these two options, one being the Cleopatra regimen and the other TDXD plus pertuzumab. I mean, there is definitely a lower risk of neuropathy without the use of taxanes, but TDXD is not an easy regimen to tolerate. And you can see that there is a higher incidence of nausea, vomiting, and fatigue, which might be quite hard to tolerate even for if we are focusing, for example, in older patients. Even if these are grade 1 to 2 toxicities, this might be hard to tolerate for older patients in the long term. So, and we cannot also ignore that TDXD does have a high risk of some adverse events that might be quite severe, such as pneumonitis. And there were actually some treatment-related deaths in this trial. So I would say that, I mean, we cannot ignore that this is a large PFS improvement of over 1 year, which I do think it's clinically meaningful. But this strategy does have a different toxicity profile. I would wait until we have some quality of life data so that I can include this information in my conversations with patients. But if I were in a setting where I had routine access to TDXD in the second line, I would only recommend this at this moment for patients that might be at a higher risk of not actually getting to the second line. Patients with visceral metastasis, those with brain metastasis, or maybe those with hormone receptor negative status, which may not have any other strategies to add on to maintenance treatments. And we also cannot ignore that access to any HER2-targeted treatment is still a challenge in many parts of the world. I mean, we're talking even with trastuzumab. And this strategy does definitely add to the costs of treatment, both through the medication itself, but also through added scans that we might need to do, for example, to look out for pneumonitis and make it safer to deliver this regimen. And we know that there are actually some pertuzumab biosimilars that are under review. So the differences in costs in a couple of years might be even longer.
Thank you. That was quite comprehensive. And we have like 4 or 5 comments in the chat. I'll try to summarize them and answer. Absolutely, I think this trial does not answer the most important clinical question, which is, should we give it first line versus give it second line? Because there is not adequate crossover, so we don't know whether giving it first line improves outcomes over giving it on second line, because the control arm patients, many of them, they did not get trastuzumab deruxtecan second line. So that is a big problem. If you think about Cleopatra trial, it improved OS substantially. If the drug is really good, it will translate to OS improvement. So without OS, I hesitate to say that this is going to change practice, especially when the control arm patients are being deprived of getting trastuzumab deruxtecan ever. So it becomes a trial of ever versus never. The second point is about informative censoring. The PFS curve looked, there is heavy censoring there, but of course, we don't have that exact data. New England Journal does not provide that number in bracket. And that is one of the points that CSO checklist is making, is that all the trial publications should have that censored patients in brackets so that we can look at the rates of differential censoring, because many of the PFS gains can be explained by differential censoring alone. So we don't know if that's the case here. And of course, if PFS really has improved by that much, it should translate to gains in OS or gains in quality of life. And we don't know that yet. And about Runchi's question about patient involvement in most of these trials, again, that is one of the point of CSO checklist. CSO checklist says patient and advocates should be involved in trial design, should be involved in each part of this trial reporting and discussion. But as far as I know, correct me if I'm wrong, patients have not been involved in this trial design or reporting or analysis, except for just getting enrolled, which is something that CSO checklist talks about. And there was one question about, is there any biological rationale of combining pertuzumab with trastuzumab deruxtecan? I don't have an answer, but if Haydee, if you know any biological rationale for this combination, Please go ahead.
Basically trying to overcome some resistance mechanisms, but not.
Yeah, and
yeah.
Okay, yeah. So we don't know the answer to that at this time. But the other important comment that is being made is what to give second line if we are using this first line, and that is absolutely correct. And that's why we need to see OS improvement over patients getting it at second line. The question is not should patients ever get it. Of course, this is a good drug. They should get it at some time. The question is whether they should get it first line or can we reserve it for second line for only those who progress into second line. So that's why this trial is not answering that question. We'll move on to the next trial.
Okay, so we're switching gears here to head and neck cancers, which also is hot off the press from the recently concluded ASCO meeting in Chicago. So the trial NIVOSTOP, as the name NIVOPOSTOP, as the name suggests, is nivolumab, use of nivolumab, which is a immunotherapy drug, post-operative, setting, which is usually patients who have resectable disease to begin with, meaning they have fairly early or locally advanced disease and not metastatic of the head and neck cancers. And this encompasses all the way from the base of the skull in terms of definition of head and neck landmarks to above the clavicle bones. A bit of background is that 40 to 45% of these patients, despite having resectable disease, will have at some point a recurrence of disease, meaning that patients will have a disease coming back after the surgery. And historically, the standard of treatment in that setting used to be either adjuvant radiotherapy or actually concurrent adjuvant chemo plus radiotherapy. So this trial is testing, can we advance those numbers of, by adding nivolumab, which is an immunotherapy drug, to the standard practice post-op in terms of recurrence. So this is the schema. I will not go into much detail. It's a simple randomization. Patient who had oral cavity cancer, oropharynx, larynx, hypopharynx, these are all collectively called head and neck cancers, were randomized to either receive nivolumab after, after surgery, meaning that they had some sort of high risk factors for recurrence. Lymph nodes are positive, margins are positive, lymphovascular invasions, and all that. So they were either given nivolumab plus chemo plus radiotherapy, and then maintenance nivolumab, or the good old standard of care, which is just cisplatin and radiotherapy, which is at 66 gray, using somewhat the best technology that we have currently called IMRT. And the primary endpoint for this trial was DFS, which is fairly acceptable according to the CSO clinical trial checklist. This is a post-operative and setting trial. Disease-free survival is a fairly acceptable primary endpoint. And key secondary endpoint here was overall survival. So this is just a patient population, male, female, smoking status. As you know, that's a high risk factor for head and neck cancers. Tumor subsite, there was oral cavity, majority of them are oral cavity, and some of them actually were HPV positive, which is a common phenomenon these days in head and neck cancers. On the right side, in terms of the indication for postoperative radiotherapy, you see there were positive margins and also, the stage of presentation as well. So this was the result of this trial, and basically the long and short of it is that Nivo given post-operatively with chemo plus radiotherapy, despite that being a triple modality, and we can discuss how toxic or how and more is good or less is more, showed an improvement in disease-free survival compared to cisplatin and plus radiotherapy. If you look at here, the margins here looking at 63% and 52% favoring Nivo plus chemoradiotherapy. This doesn't go without drugs, without any toxicity. These are triple modality treatment. More is not always the best. As you can see here, grade 1 and grade 2 following the key on the left, on the right side, in terms of the color markings. Grade 1 and grade 2 were actually common in terms of stomatitis, radiation skin injury, that is from the radiotherapy, nausea, dry mouth, which is really inconsistent with most of these off-target immunotherapy side effects and resulting from stimulation of the immune system as a drug. So the conclusion here is that primary endpoint was met, as you have seen those curves separating. Disease-free survival in this setting was significantly improved with a hazard ratio of 0.76, meaning there's a 24% reduction in the recurrence of disease. There was a moderate increased toxicity as expected, but as you have seen in the previous slide, there were fairly fewer treatment-related deaths, specifically with regards of immune-related toxicity from the nivolumab addition. Therefore, the authors suggested post-operative nivolumab can be actually used as a standard of care and in combination with cisplatin and radiotherapy, especially for those patients who are high-risk factors in terms of post-op and features. But we can pause here for a minute and talk about actually the head and neck burden in low and middle income countries, especially in Kenya and in many African countries. The standard of care right now is that chemo plus radiotherapy. But if you actually take a step back and see how many patients in most of LMIC's low and middle income country, in terms of head and neck cancers, present as at a resectable stage, those are far and few between.
One important thing about this trial is that with the dose of immunotherapy, we have many evidence now to say that immunotherapy can be used at a far lower, ultra lower dose. So, treating one patient with full dose can be equivalent to treating almost 200 patients with an ultra low dose of the same immunotherapy. So that is something that needs to be explored more. And as Omar was hinting at, several LMICs, they don't even have access to radiotherapy machines. So in that context, the global applicability of these results will be a problem.
Okay, so the next one we'll be discussing is ATOMIC. And this was a randomized trial of immunotherapy in the adjuvant setting for colorectal cancer, specifically for patients, for that 10 to 15% of patients with deficiency in mismatch repair proteins. So we know that this is around 10 to 15% of patients with stage 3 colon cancer, but prevalence might be different in some other stages. So the idea for this was to add on an immune checkpoint inhibitor, in this case, atezolizumab, to the standard of care, which is currently chemotherapy. This trial enrolled patients from 2017 to 2023. So at the time, I think when this trial started, we didn't have yet results from the IDEA collaboration. So they chose 6 months of FOLFOX as their standard run, which was appropriate at the time. They used disease-free survival as their primary endpoint, which is found to be strongly correlated with 5-year survival in this setting, which also seems appropriate. And after they completed combined treatment with atezolizumab and chemotherapy, they went on to receive 6 months of additional treatment with atezolizumab. This was a positive trial for DFS. And at the 3-year mark, this trial showed an improvement of around almost 10% with the addition of atezolizumab. This was the follow-up at this time was quite decent, but overall survival data are still immature. To put this in context, I'm showing here some of the results that we have from the ACCENT collaboration, in which we know that patients with oxaliplatin-based chemotherapy with microsatellite instability have a DFS at 3 years of around 85%, which sounds quite larger to what we saw in this trial. But looking at this, at this moment, it wasn't common practice in trials to stratify patients by many novel factors, such as the risk group that we started to use more commonly in practice after the IDEA results. So in this trial, they had about 54% of patients with high risk features, such as a T4 tumor or an increased number of lymph nodes. If we go back to these results from the ACCENT collaboration, we can see that definitely patients do have different outcomes. Even those patients with MS, microsatellite instability, they do have different outcomes depending on their risk category. And their DFS at 3 years might range from as high as 90% for those at low risk, but as low as 64% for those at high risk. So at this moment, we only have relative improvements in DFS that were shown in the ASCO presentation, but it would also be interesting to see what the actual absolute improvements in DFS are for these separate groups and whether there would be any larger absolute improvements in DFS in these two separate groups. So there is some increase in toxicity with the addition of atezolizumab, which does make sense. There were some additions, some increases in basically the things that we know that happen with the addition of immunotherapy, such as endocrinopathies and some colitis, myositis, and a very, very slight increase in hepatitis and pneumonitis. But there were also some interesting things regarding neuropathy that they did discuss as an unexpected signal, whether there is any interaction from the use of atezolizumab and oxaliplatin-based chemotherapy on both neutrophil counts and also a slight increase in peripheral neuropathy, which is not yet quite understood what this happened. As far as I know, this is not something that we've seen in other GI cancer trials. So does this impact routine practice? I think this is a large DFS improvement, and we know that DFS is a validated surrogate endpoint, so I would say that this is a practice-changing trial. This is a regimen that does add some toxicity, and I would also like to see, as I was saying, the information on the absolute benefit in different populations according to the risk category, which improving on someone that has an expected DFS at 3 years of 90% might be not as greater as someone at a higher risk. And this is especially important looking at this through a global lens because, while this is an effective strategy, it definitely does add significant financial toxicity to a treatment that we know is not as expensive. And there is also the question on whether this is the best strategy for patients with MSI high tumors, or whether it would be actually better to implement immunotherapy in the neoadjuvant setting, which would actually allow for potential de-escalation of treatment, although this is not yet a proven strategy. But I think one of the other key issues here is that this evidence does support that we should be universally testing of all of our patients with colorectal cancer to determine their MMR status.
Thank you. Again, this was an excellent summary, and I think we can also discuss in the context of MATTERHORN trial later. But two key things to discuss here is de-escalation of treatment. One is in terms of, even like chemo, is it even needed if you are going to treat with immunotherapy for these patients? Because there are some data from Pembro and Nivo plus EP as well. So is FOLFOX even needed here? But B, more importantly, what is the duration of immunotherapy that we are looking at? Because there is no evidence to say that it is needed for 1 year. And this is an adjuvant-only trial, but MATTERHORN is a perioperative trial, which we'll discuss immediately after. But if we do neoadjuvant, is the adjuvant component even needed? So there are a lot of opportunities for de-escalation here. So I hope that is answered in future trials. But we can discuss that in the context of MATTERHORN as well. I know that Omar is back. So Omar, do you want to take on the MATTERHORN?
So moving on swiftly, the perioperative trial that was just published in the New England Journal of Medicine. This is a trial looking at the rationale of combining
Davalumab, which is also another immunotherapy, to the winner of actually control arm winner of ESOPAC trial, which was also practice changing at some point, FLOT, to improve the the survival and also pathological complete response or resectability. Yes, so the schema for this trial is a global phase 3 trial, randomized placebo control. The study population here are gastric and esophageal junction tumors, which are more or less treated the same as PASIWAT criteria. Stage 2 to stage 4A was accepted in the enrollment of this patient at some point. Who are enrolled in this trial were not having a distant metastasis. They were fairly in good functional status. And the countries there, again, Asia, Europe, North America, and South America. The randomization is that you give 2 cycles of immunotherapy alone arm. You go to surgery, then you give another immunotherapy plus now the chemotherapy, and then you maintain. That's a long schema right there. On the other arm is the traditional FLOT regimen, which was the standard of care for a long time. FLOT is just an acronym for fluorouracil, leucovorin, oxaliplatin, and a taxane drug, and in addition to a placebo matching here the development on the experimental arm. And then they went to surgery as well, and then now maintaining the same schema, placebo in place of development, and then placebo as well. The primary input here is, and here is where we need to pay attention, is event-free survival. And secondary endpoint here is overall survival and pathological complete response. So the curves, the Kaplan-Meier curves here, as you see the difference between the two, and you're looking at the 1-year mark in terms of event-free survival, again here defined in terms of even all-cause mortality or disease progression, or as per defined by the authors, was 67 versus 59. Fairly a smaller margin in terms of the differences. But again, as they say, if you can put a pointer between the, as Bishal like to say, between the curves, this gets a planned recession as it was. So the median EFS, event-free survival, was not reached. And again, people on the call here, meaning here, not reached, favoring actually that this is still having more of a benefit compared to the placebo plus FLOT arm, which is only at 32 months on the upper right corner of this slide. Hazard ratio was 0.71, meaning around 29% reduction in event-free survival. We're very interested in overall survival. If you're bringing, immunotherapy forward and adding it to a very toxic regimen, which is FLOT, then it's at some point it should really translate to an overall benefit, overall survival, as which is really what matters to a lot of patients and their families. And here at 24, there was only 6% difference between the two in terms of overall survival. Next. So I think R0 resection is quite important because this is a preoperative R0 resection is quite important because this is a preoperative trial, meaning here the main aim really is to make sure you shrink the tumor so well that the surgeons really have very few work to do in terms of resectability of the remaining tumor, and that way patients get a fewer or a less burden of disease remaining, which can be cleaned up in the adjuvant setting. And here clearly showing a difference of 75 versus 66, favoring the immunotherapy and the FLOT combination. So PCR, I think I've mentioned this. It's a no-brainer. The more you give in terms of the immunotherapy plus FLOT, this actually is more rationally acceptable in terms of giving 3 drugs than 2 drugs versus the event-free survival, in my opinion. So in the conclusion of this trial led by Janjijian from Memorial Sloan Kettering in New York, the conclusion is that the addition of davalumab improved event-free survival in resectable gastric and gastroesophageal junction adenocarcinoma. Again, reflecting on this part of the world, and presentation is also again resectability presentation for our patient in most part of the world might be a bit lower than this cohort of this study. So the external validity of such trial might not be really practical. But nonetheless, the data is right there. If you add development in the front side setting, in the neoadjuvant setting, in a patient that you really want to reduce the burden of the disease, might be something to consider.
Thanks, Omar. So in the interest of time, I just typed the discussion points here, so people can read in the comments. Yeah, one thing that I did not have the time to type here is also about the dose. Can we use a lower dose? But also an important point to discuss here is about contribution of component. Is the adjuvant component even adding anything? And is neoadjuvant alone enough? Because we see that in melanoma and lung cancer. So in the interest of time, we'll move on to probably the final trial for today, which would be the challenge trial.
Okay, so we'll move on to from drug trials to discuss exercise. So the challenge trial was conducted in patients with resected colorectal cancer, and basically patients who had received adjuvant chemotherapy for colorectal cancer. They were mostly stage 3 patients. The median age was 61 years, which I will discuss in a moment why that might be important. As this trial was conducted in between 2009 and 2024, we have a wide variety of treatment regimens. FOLFOX, most patients did receive some oxaliplatin-based chemotherapy, but we don't have any information on duration of chemotherapy actually from this trial. So patients had to be reasonably fit, and by that I mean they underwent a baseline fitness testing, but they shouldn't have been that fit in that they patients to be enrolled in this trial had to be exercising for less than 100 minutes per week. This considering moderate to vigorous exercise. So we know that many of us, I think, when patients ask about exercise, what we say is basically, yes, you should exercise, do it as best as you can, and that's it. Some people might have some additional information that they provide to their patients through structured materials, pamphlets, things like that. And this was basically the control arm in this trial. And the experimental arm was this educational material, and then on top of that, very complex and extensive intervention that I will discuss. And they aim to look at the impact on this intervention on a primary endpoint of DFS. Similarly to the ATOMIC trial, as we know, this is a validated surrogate endpoint in this setting, and some other secondary endpoints that we will also be discussing. So the interventional arm consisted of a 3-year intervention of 3 phases. The first phase was quite intensive in that it was basically a behavioral change intervention. Patients had the support from a physical activity coach that provided behavior support sessions. In the initial phase, these were face-to-face, and then over time, they were allowed to have those sessions either face-to-face or through telephone, email. And they were also planned to have initially supervised exercise sessions that over time, as the intervention progressed, they were no longer mandated, but they were strongly recommended. And the idea for all of this was for patients to increase their physical activity from their baseline by 10 MET hours per week. I'm putting here what does a MET hour mean. So basically, an hour of brisk walking is equivalent to 4 MET hours. So if we're thinking about 10 MET hours per week, that means that patients should then be walking for 2.5 hours more over a week than they were doing before the trial. So the behavior change techniques that they used were quite extensive as well. But I think this is quite aligned to many behavioral change interventions that we might also see on the psychological side of things as well. The coaches discussed with patients things as how to set their own physical activity goals, provided some feedback on the fitness appraisal that they underwent every 6 months. They discussed how to self-monitor their own progress and how to self-assess their own barriers to physical activity, whether it's in their environment, through social support, and actually just by making physical activity fun and feasible to implement in their daily life. So this was a positive trial under primary endpoint of disease-free survival with a 6.4 difference on DFS at 5 years. The DFS endpoints were mostly related to recurrent events of colorectal cancer, but there were also some decreases in new primary cancers, mainly those that do seem to have some association with metabolic status and weight and other similar parameters, such as breast and prostate cancers. And the trial also showed a benefit on overall survival by a decreased hazard ratio of 0.63. And similarly, most of these deaths were related to colorectal cancer, and most of the deaths were cancer-related in general. And as you can see, these curves begin to separate at around like the 4-year mark, while the disease-free survival curves, we start seeing a difference at an earlier time point. And I wonder if this is because one of the things that I will show in the next slide, which is that patients, even if they were less adherent over time to the intervention, some of the metabolic and physical activity parameters that they measured over time continued to show an improvement. So I wonder if this overall survival benefit could also be partially explained just by the plain fact that when people had a disease recurrence, they were actually fitter and more likely to be eligible to receive palliative treatment for that recurrence. Going back to the previous slide. So this is, since patients could choose the type of physical activity that they preferred, toxicity and related side effects were within what we would expect from someone increasing their physical activity, and mostly related to musculoskeletal and fatigue and those kinds of things. No surprises there. And interestingly, as I was saying, 70% of patients received oxaliplatin, and there were no concerning signals regarding neuropathy or other similar side effects. Yeah, so as for the impact on routine practice, there is a large DFS benefit. This is roughly similar to what we are seeing also in the ATOMIC trial. I would say this is overall a low-risk intervention in terms of side effects, but this is a significant time investment and for patients with potential added financial burden depending on their life circumstances. And as I'm seeing some comments in the chat as well, this is something that it's might be quite difficult to implement at institutional or organizational level without any additional support on that side as well. And the trial did collect some samples to assess from potential predictive biomarkers on metabolic pathways and things like that that could perhaps point to some patients deriving special benefit from this intervention. Regarding applicability, this trial did have issues with accrual. This took over 15 years to complete. And this does bring questions of actual feasibility of these types of intervention outside of the trial setting. And I am also concerned about disparities in access to this intervention. We know that certified physical activity consultants might not be available in many parts of the world. And there might also be some impact and difference regarding social determinants of health within this intervention. Going back to patient characteristics, these were mostly median age was patients in their 60s. And these patients were mostly recruited in high-income countries. So many of those patients might actually be no longer working. They might be retired. They might have time to invest in these kinds of interventions. If I'm thinking about many of the patients I see in my practice in Mexico who might be younger, still working, have to provide for their family, have long commutes, it might not be easy for them to implement this into their routine life, even with all of this support. And so I think this is one of the trials that might need a replication and trying to do this in a more pragmatic setting. I mean, we have I think this is strong evidence that there is a benefit on implementing this in our patients. But I think the next step is seeing how we can actually disseminate this across many settings, and whether these changes that we make continue to ensure the effectiveness of the intervention. There's this paradox of the Theseus ship and how many things of how many parts of one thing you can change before if it stops being the same thing. So I think that is definitely something to consider.
Thank you again. Yeah, I mean, one of the commonest comments that I saw on social media when this trial was published was that, okay, this looks great. I'm going to ask all my patients to exercise from tomorrow. But we need to be mindful that that is the control arm. That is not the interventional arm. Telling patients to exercise is helpful, is the control arm of this trial. The experimental arm is to actually have that package, providing the physical trainer and that whole package. So that is an additional comment that I wanted to make, that asking patients to exercise is the control arm of this trial. And yeah, I think, does it work? Absolutely. Like, it's not even just DFS, there is a substantial improvement in OS as well. Can we make it work is the real challenge, and that's where we need to. And one comment in the chat is about confounder. I think I would not worry about confounder because this is a randomized trial. Randomization is supposed to take care of known and unknown confounders between the two arms. So yeah, but like I know that we are going beyond time, but we still have two more studies that we are planning to discuss. So in the interest of time, I'll ask Omar to summarize them very succinctly, but I don't want to leave them out because they are important for global oncology relevance. So these are the studies about the timing of immunotherapy and the ultra low dose immunotherapy across solid tumors. These two studies, Omar, if you can summarize the main takeaway in a few minutes, then that would be great.
So time of the day, a bit of background in 30 seconds. Immunologists keep talking about our immune is very active during early hours because of cortisol, parallel activity of cortisol, circadian rhythm, and whatnot. So this trial was actually done in my school where I did residency in China, which I'm very proud of. They looked at just basically lung cancer patients, go to the schema, lung cancer patients, if they are given the immunotherapy drug before 3 p.m. or after 3 p.m. I know that's very subjective. People might say that's not too early, but there's a certain thing they talk about in terms of circadian rhythm, and you'll be surprised. Just go to the trial result, and this was very interesting, and it got a lot of attention. The progression-free survival right from the beginning separate, and in favor of actually if the immunotherapy is given early during the day than later in the afternoon. And look at that curve separating a difference of almost 11.3 months versus 5.7 months, hazard ratio of 0.42. Next, overall survival, which is a key marker, also was very significant. And you see the difference is the overall survival of the patient actually who got the immunotherapy in the morning has not still been reached. So they're still doing very well somehow. And the other ones actually is only median overall survival was 16.4. So food for thought. That's what we want to talk about in this trial in a nutshell. The next one is about the utilization of low-dose immunotherapy, which is really a repurposing an idea of bringing this expensive monopolized immunotherapy drugs only in the Western and the first world countries. And this was a very interesting trial. In summary, go to the schema. In summary, this trial was more of a basket trial. It took all patients who were PD-L1 positive, which is a marker for sort of response for immunotherapy. It contained lung patient, head and neck cancer patient, esophagus, tumors with MSI high, like colorectal, all of them. And they were just basically divided into lung cancer cohort and non-lung cancer cohort. But the long and the short of it is that they randomized a low dose, 20 milligram. I think that's where everyone should pay attention. 20 milligram, which is, I don't know how many fraction of what we give right now and with this market share versus chemotherapy choice. And this was quite open. So it could be, if you look down there, it could be head and neck, the common chemotherapy regimens, and esophageal chemo, paclitaxel, easy, cheap drugs, and a low dose chemo and nivolumab, which is more affordable. Results, there's clearly separation of the curves there. Not quite really much of a difference, but it just tells you a very proof of concept that these drugs actually, if they were brought to LMICs, low and middle income country, and even tried with a fairly lower dose in a larger randomized trial, then this might be something that might actually stumble into, we might stumble into something that might be bigger than what we see. Go to the limitation. This was the last slide. So it's a single center study from Tata Memorial in India. There was a diverse group of tumors. So there's a lot of heterogeneity. So it's not powered to assess an individual type of tumor. And just like immunotherapy and chemotherapy, there's no PK, pharmacokinetic, pharmacodynamics data available to see actually all these. So the authors actually trying to nudge this, that this can be really tried in more predominant cancers that are common in LMICs, and such a dose, or even in a larger randomized trial, phase 3, and not single center and a basket type trial. That will be very interesting in my opinion. Thank you.
Well, thank you. Both these trials are very interesting and very, very globally relevant. I find it a little hard to understand that for drugs like immunotherapies that have such long durations of actions, when they get the dose would matter so much. So I would ideally want to see this trial replicated in other settings. However, like there is no downside to this. Like you are going to give them immunotherapy anyway, might as well give them in the morning. So this is something that we can immediately change practice, with the caveat that, even if the results are, let's say, not true, there is no downside to it. But I would ideally want to see this replicated in other settings. But this is very fascinating. Like so much of a difference. It's not a small difference. It's a huge difference. And if that is true, should we be thinking about timing of doses in other settings for other drugs as well? Does that make sense? Anyways, and for the last trial, ultra low dose immunotherapy, especially after some of these immunotherapies might be available as biosimilars in next few years. This would be very, very meaningful and practice changing for patients globally. So yeah, we are sorry that we had to go 15 minutes beyond the promised time, but I think it was all worth it. And I really thank you all for staying with us until now. I hope this was a meaningful conversation and some food for thought for all of us. We regularly do webinars at CSO, so please stay in touch, stay connected, and we look forward to seeing you again next month, maybe with the next webinar. So thank you everyone for joining today, but special thanks to our 2 CSO fellows who did such a wonderful job. And looking forward to doing this again, maybe after ASMO.